I am Dr. Dutta. I'm an endocrinologist based in Dwarka, New Delhi, and it's a privilege for us at SpeedCon 2020 to have with us Professor Zvi Laron, all the way from Tel Aviv, Israel. Sir needs no introduction in the field of endocrinology, but for all the other doctors from different specialties, let me have the privilege of introducing him. He is one of the most eminent endocrinologists, specifically pediatric endocrinologists globally. He has done some path-breaking research in terms of managing children with difficult to manage short stature, focusing on growth hormone resistance. We have the Laron's dwarfism named after him. He has also done some path-breaking research with regards to optimal management of children living with diabetes, and also a different spectrum of endocrine disorders from childhood obesity to disorders of sexual differentiation. Welcome, sir, here to India. For the audience, they are fascinated to learn from you how has been your journey with endocrinology in the last 60 to 70 years.
Well, thank you very much for the invitation. It's my pleasure to be again in India after many years. My journey is a long one. I have the privilege actually to be part of the development of endocrinology, which started in the 1950s. And when I went to the United States to do a postgraduate study in metabolism, and I ended up with metabolism with endocrinology. There was a time of Nathan Talbot and Lawson Wilkins, who were the basics of pediatric endocrinology. I also visited the first time that Morris Rabin in Boston injected growth hormone in 1957, and he showed the effect of purified human growth hormone extracted from human pituitaries after death, to see that it has an effect on the metabolism of the human being. There was also a time which was very interesting, that a radioimmunoassay to measure growth hormone was only 5 years later, so that one could diagnose if you have a deficiency in growth hormone secretion or not. And since then, the development ran. There were not enough pituitaries after death, so that in 85, the biochemists were able to recommend biosynthetic growth hormone. But then again, it was found by Dr. Doherty that growth hormone does not act directly, and there was a sulfation factor, which ultimately ended out with somatomidin, and now it is called IGF-1, and is actually the duet of growth hormone and IGF-1, which makes children grow, and which play also important role in carbohydrate, protein, and fat metabolism.
Absolutely.
I had the privilege to go back to Israel in '57, and one of my teachers invited me to the hospital where he worked, and which was the foundation of the Tel Aviv University, where he gave me a research laboratory as well as a job in the Department of Pediatrics. And at the beginning I was the doctor, the secretary, and the laboratory worker. I had to do everything. And as I say, the times advanced. The important thing that I learned in the United States and coming back is that pediatric endocrinology patients are treated by adult endocrinologists. One of my jobs was to take out and to form a department of pediatric endocrinology, because the children have different needs than adults. And the same is true for chronic diseases. And one example of that is diabetes. So thus I found out that by simply advising drug is not enough in a chronic disease. You have to adapt to it, especially in diabetes where you don't have a cure. You didn't have a cure then and you don't have a cure now. So that therefore I understood that the psychosocial problems are so important that I formed my group. I took in psychologists and social worker in the department of pediatric endocrinology, forming a multidisciplinary team so that all of the aspects could be discussed together rather than sending the patient to a department of nutrition, department of social work, etc. And thus we were able, what we think, to give a better treatment. Still not optimal, because children are very difficult to understand that they have a chronic disease and do not have the look into the future. Neither do the parents. So much work had to be done with the parents, with the multidisciplinarity. Now, with the time endocrinology developed, there were radioimmunoassays for others, and the patients from Israel were sent to our clinic. We were really doing the demography of insulin-dependent children, and we found then, and this is going on, that the increase in incidence, and we feel that it is a matter of viruses which cause the damage to the beta cell already in utero. And therefore, the large part of diabetes is caused by infection of viruses. Although we know there are other environmental factors, pollution, etc. So otherwise we had a lot of problems we described TRH test among one of the first. We were the first to treat the patients with LHRH. We received it from Shally by mail in the powder, and we made it up in our laboratory, in the pharmacy of our hospital. We were among the first to treat precocious puberty also with cyproterone acetate. And so that the other thing that we found is that I saw that there are not enough interaction between the pediatric endocrinologists in the world. So that we started international symposia, which led to the development of the European Society of Pediatric Endocrinology, of the Growth Hormone Research Society, and so that we formed a large group which at the beginning was meeting every year in a different country. At that time we had 100 to 300. Nowadays it's grown into several thousand, and so that the personal relationships are not the same as they were before. Now, in our group also, especially in Laron syndrome, we had Dr. Desai from Mumbai, yes, who came also already in the earlier years to show that there are patients in your country here. And so that in a way the pediatric endocrinologists having the opportunity to meet form social relationships, personal relationships. When we were small, we could meet in the house of the various things. Nowadays, it is impossible. We also introduced social days, meaning after the meeting of either diabetes or general endocrinology, we had one day of touring Israel, but then the demand was to more, so we did 3 days of meeting and 3 days of touring. Now, the touring was not only tourism. We were together, so it really formed friendship between the families, because very often the endocrinologists were also came with their partners, either wife or husband. So the relationships were, I would say, extremely personal. Unfortunately now the meetings are so big that to do this kind of social program, it has decreased to, even for the latest program of the largest thing, it has stopped completely. So I feel that there is a deficiency in the personal relationships. And the relationships nowadays is by the smartphone. This is very... Now, I would like to say at the end that I'm very glad to be here. And as it is, you meet old friends, you make a lot of new friends. And I would also like to mention one activity in our 17 years. We formed the Pediatric Endocrinology Reviews, a journal which is now read all over the world, and having the contribution of the experts from all over, and I hope also that nowadays, being here, we shall be able to receive also manuscripts from India.
That's a wonderful proposition by Professor Laron. It was such a wonderful journey. It was so nice of him to share his views, how the practice of endocrinology evolved, how he was the pioneer in using human extracted pituitary till we had recombinant growth hormone, how the use of LHRH revolutionized the treatment of children with precocious puberty.
I may say one thing which may interest the audience, if there will be. Namely, we found that the type of dwarfism we described, Laron syndrome, are immune to cancer. They are, and we found that also patients with congenital isolated growth hormone deficiency are the same. The homozygotes are protected for the whole life to develop cancer. Although they are obese, also they are... The heterozygotes, meaning parents, siblings, are not. So what we do know, even as treatment is possible, and our insurance companies pays for IGF-1, whoever needs it, I think that if the parents still, if there are still parents who are consanguineous, we do pre-gestational diagnosis and interrupt before. That means we grow the embryo in vitro and implant only the healthy embryo, and not, because it is quite a burden to have a child who has treatment but it's still insufficient.
That's a great way of primordial prevention, and there comes the importance of social medicine, which Professor Laron beautifully highlighted. It's not only about treatment, we treat the family as a whole, and the aim is to prevent the disease. So it was really wonderful and fascinating listening to your beautiful journey in the field of pediatric endocrinology.
If I may say one more word, is now we are researching what is the cause which protects against cancer. Hopefully, if we know it, and still we don't have it yet, it may help also for other cancers.
Amazing. So from pediatric endocrinology, the larger perspective of how the importance of growth hormone and IGF lies in the genesis of cancer to even prevention of cancer. That's a great message by Professor Laron to entire medical fraternity here in India. It was a privilege listening to you,
Can I
sir.
say one more word?
Of course, sir. It's yours. Yes.
Now we work on the prevention of type 1 diabetes in children.
Yes. Yes, that's great. Yes, a lot of immunotherapy and fascinating molecules are coming up with regards to that. So maybe you'd like to add something with regards...
On my next trip, I'll tell you the results.
Oh, amazing. So we have now some food for thought regarding prevention of type 1 diabetes. It was really wonderful listening to you, sir. Thank you so much. As we say in India, namaste.
Bye.